enteral feeding of the oncology patient. How many of you guys are working in oncology? Okay, good. But want to talk a little bit about different guidelines that are out there, how they complement each other, strengths and weaknesses of those, how we got there, all those things, to see how we can move the field forward and make sure that we're doing the right thing for all of our acutely needing nutrition health oncology patients. I have nothing to disclose. And here are my learning objectives. But before we get started into the meat of mainly what I wanted to talk about, I do like to always, when I get the chance to talk to a bunch of people, and probably preaching to the choir as far as this population goes, but I like to bring it up anyway, that feeding tubes in any population, but this population especially, who are probably struggling with stress management and treatment-related side effects and anorexia hormones and all these things that are working against them, we shouldn't be using feeding tubes as an ultimatum or a punishment. And the way that we introduce it to them can change the way that they tolerate everything, that they can feel like they're not failing at their treatments, and that we're not against them, that we're part of their team and we're here to support them and use love and nutrition and all those things to get them through it. So I'm usually pretty quiet and reserved, but if you say this on rounds, this is when I'm going to chime in. You know, we shouldn't be using this as a, you know, we're going to punish you, and the patient is the ultimate person that gets to make the call anyway. So it's an irrelevant statement anyway, because they're the boss in the room, and we're just trying to help. So be kind whenever you are introducing these things. ASPEN Cancer Fact Sheet, if you haven't got to look at it, is very good for pulling resources, particularly if you're talking to patients or administrative people, because they have some good data on there and pulled it together in a nice fashion that's easy to read. They talk about up to 80% of cancer patients have a prevalence with some level of malnutrition at some point during their treatment, and so that's almost everybody by themselves there. And then up to 20% of cancer patients die from the malnutrition and not the underlying disease. And that's where we really have to do better for people. We can't let that be the reason that they succumb. You know, that is something that we can do something about if we catch it at the right time, do the right interventions, all of those things. So how can we do better for these patients? And then also from the revenue standpoint, they did the ASPEN studies, or they compiled the ASPEN studies and showed a $242 million savings for Medicare for GI cancers with early oral nutrition supplements and early enteral nutrition before it was too late. Oncology evidence-based nutrition practice guidelines from the Academy. They have a lot of good resources on there. It's a little bit older now, it's 2016 paper, but the resources that are on there, the amount of studies that they use to justify each of those claims are what is really a good paper to have in your arsenal if you're talking with patients or trying to educate providers as far as why you're recommending these things. That the studies provide strong evidence that poor nutritional status in adult cancer patients is associated with higher rates of hospital admissions and readmissions, increased length of stay, lower quality of life, higher mortality, with decreased tolerance to chemotherapy and radiation therapy. So preventing the malnutrition, not only for them for having the mortality, but also can we increase their quality of life? What can we do to give the time that they do have, regardless whether it's curative or non-curative? How do we make sure that they have the most to recover with, not fight with one hand behind their back? I really love this. This essentially, this flow sheet summarizes almost everything that we're going to talk about today. It's on the ASPEN Cancer Fact Sheet if you haven't got to look at it yet. It's a great one, talking about how we kind of move through this, where nutrition assessment, and then is nutrition support indicated. So the nutrition assessment part can come in a lot of different ways, whether you're being consulted, whether you're working on trying to get screening protocols into your institutions, because that's where a lot of the literature is showing that we need to do better. That we're screening people. The malnutrition screening tool has been standardized for both inpatient and outpatient, so that's a great one to use and easy for non-nutrition staff to kind of pick up and trigger people for. But getting in front of people doing the nutrition assessment, looking for malnutrition and opportunities. Then if nutrition support is indicated, is oral intake possible? If yes, then is the appetite normal? If no, then orexigenic agents. So most of the time that's Megace, Marinol, even though that's off-label, dronabinol, olanzapine, mirtazapine. If they're have a neuroendocrine cancer, then sometimes cyproheptadine, because that can help with the neuroendocrine diarrhea and stimulate appetite. But a lot of different agents out there, which is another talk altogether. And then diet and ONS education, trying to get as many calories in as we can to avoid needing more invasive therapies. But if that doesn't pan out, then assessment of stage and treatment plan for as far as their cancer goes. So are they curative intent? Do they have further treatments, or are we at the end of the line? There is no more treatment, so is nutrition support indicated at that time? We'll talk a little bit more about that later on. But if they are continuing treatment, there's things that we feel like we can do to help them. We assess whether their GI tract is functioning and whether we can access it, which we'll talk a little bit more about. And if so, then we can start our enteral nutrition, but we have to take into account patients' desires, life expectancy, and performance status. Most of the recommendations from around the world and studies that we're doing, you can use nutrition, particularly enteral nutrition, through the whole process, but if they're at that very end of life, it doesn't seem like we help anybody if we initiate some invasive therapy. So usually the last 3 months of life, if they're not anticipated to live longer than the next 3 months, then that's when we see that we don't really help anybody. Or not that we don't help anybody, but that maybe it's not the best thing to be doing for them. So in 2009, we had the most recent update from ASPEN. We're going to talk a little bit about the consensus statement paper that we just published that's available online a little bit later. But as far as guidelines go, because our paper was just consensus statements, 2009 is still the most recent thing that we have as far as cancer goes from ASPEN. And again, they recommend that patients nutritionally at risk should undergo nutrition screening and then see who needs to see have a formal nutrition assessment and develop a nutrition plan of care. And the earlier the better as far as that goes. Nutrition support should not routinely be used to undergoing major cancer operations. So a lot of times they're going to say routinely. That just means we shouldn't be offering that to everybody. But if they have indications for tube feeding, TPN, they have malnutrition going into it, we can't access the GI tract, you know, all those things, those still apply. So it's just, we shouldn't be offering that across the board and just putting tubes in everybody. That's what they mean by routine. But we should be doing it in people that have the indications for it. Perioperative nutrition, and particularly in the 7 to 14 days preoperatively, if they are malnourished or have an inadequate oral intake, that's when we can really get some benefit. And to Ashley's point, maybe the immune modulating formulas and some of those, we'll talk a little bit about that too. Again, shouldn't routinely be used as an adjunct to chemotherapy and shouldn't be routinely used in patients undergoing head and neck, abdominal, pelvic irradiation, all of those things. So again, shouldn't be routinely used. We shouldn't be putting tubes in everybody. But if people are struggling, we can't get appetite stimulants, diet education, oral nutrition supplements, all those things going, then that's when it is indicated. And then we'll talk a little bit more about head and neck cancer. ASPEN has some recommendations coming out as far as guidelines. NCCN has some good stuff too. Nutrition support therapy is appropriate in patients receiving active anti-cancer treatment who are malnourished and who are anticipated to be unable to ingest or absorb adequate nutrition for a long period of time. Prolonged period of time is 7 to 14 days as far as they're concerned as well. The palliative use of nutrition support therapy in terminally ill cancer patients is rarely indicated. So there they talk about if they're expected to live less than 40 to 60 days, I believe, was from that paper. If they're expected to live less than that, then we shouldn't be recommending enteral nutrition unless it's still consistent with the patient's wants. You know, we would talk about futility and maybe and the side effects of all those treatments, the pain that can come from it, infection risk, some of those things, the ability to heal if we're that close to the end of life. But again, letting them drive the bus and educating them as much as possible. Use of omega-3 fatty acids to stabilize weight in cancer patients. That comes up a lot since 2009 as well. Trying to get those eicosanoids, you know, those anti-inflammatory hormone-like things going to try and stabilize weight loss. Most of the studies, at least from this paper, recommended 2 grams of EPA per day in order to get the weight stabilization, which is a pretty good dose. And there's a lot more where it's higher and lower, but that's the general consensus of somewhere around 2 grams of EPA. Patients shouldn't use therapeutic diets to treat cancer. That will come up in some of the other guidelines as well, that we shouldn't be using restrictive diets to treat the cancer specifically, and then that may raise the risk for malnutrition development. And immune-enhancing enteral formulas can be beneficial in the malnourished patients undergoing major cancer operations. Other guidelines, so ASPEN has been updated a lot more recently, and so it's one of the things that I will reference a little bit more since it was updated in 2021. Not that the 2009 guidelines were bad, it's always nice to have newer information. So ASPEN, they recommend a calorie range and a protein range in their paper, so I always like to throw that out there, 25 to 30 calories per kilogram. If you're not able to test it, we had a great presentation on indirect calorimetry. If you have that ability, that's great, but if not, then 25 to 30 calories per kilogram and at least 1 gram per kilogram of protein and optimally 1.5 grams per kilogram. These are their recommendations as far as oral nutrition, medical nutrition, and some exercise. This is just snippets from it. It's a very good paper. If you're working in oncology, I'd recommend reading the whole thing. But essentially, as far as the enteral nutrition goes, in number 11, if patients with chronic insufficient dietary intake or an or uncontrollable malabsorption, we recommend home EN and PN is suitable in these patients. They note that benefits of home EN and PN in cancer patients, even with advanced cancer, as long as their survival is more than a few weeks. So again, we don't want to do it right at the very end, which a lot of times is when they're being sent to us because we don't have great screening protocols, and that's a last-ditch effort to try and pull out the stop. But if we can get them before we're right there at the very end, it does seem to have some benefits. NCCN, National Comprehensive Cancer Network, I like to pull that one out, one, because they have really great data. Two, that's what a lot of the providers are looking at as well. They use that for their treatment protocols, and they're referencing it in their notes and things. So if you can speak their same language, sometimes it helps with getting the whole team on board as far as your recommendations go. So they have guidelines both for site-specific and palliative care. You can download their app for free and have them saved for whatever cancer types you're working with. But their palliative guidelines there talk about using nutrition support in patients with an estimated life expectancy of months to years, but not weeks to months. So again, they don't want to do it right at the end of life, but as long as we're not right there and we still have treatments and all those things, they would recommend it as well. American Society of Clinical Oncology are a little more reserved. They were updated in 2022 for the management of cancer cachexia. They lean in on sending them to nutrition professionals to talk about diet, to get orexigenic agents on, oral nutrition supplements, limiting restrictive diets, all of those things. But they talk about outside of a clinical trial, clinicians should not routinely offer enteral tube feeding or parenteral to manage cancer cachexia in patients with advanced cancer. And then they talk about, you know, if there's something like a bowel obstruction that's surgical, and then they don't necessarily talk about it as much. But a lot of theirs focus on 2 reviews that were done in 1990 and 2018, and they focus on body composition and survival with little focus on quality of life, if any focus on quality of life. And so that was, I think, one of the reasons that we see that they're a little more reserved is that they're focusing just on endpoints. Can we keep them alive? And that's just alive, not alive longer. It was just whether we keep them alive, which we're not anticipating in a palliative care case, but can we give them more time and higher quality of life in that time? And then they don't make any recommendations in their other publication there. It was mostly done. The European Society for Medical Oncology is much more nutrition aggressive, I guess. So if they have more than 3 to 6 months, they recommend, you know, normal screens, normal educations, whatever we can do in that time. So if that's tube feeding or IV feedings or any of those things, then they're for it if the other interventions and things haven't worked out. As we get to 3 to 6 months, they don't recommend that as much and focus mainly on counseling and oral nutrition supplements. And then again, at the end of life, it's just focused on quality of life, minimizing thirst, all of those things. National Cancer Institute, they recommend using it if patients are becoming malnourished or anticipated to go a long time without oral nutrition supplements or oral nutrition adequacy. I like their website and their information because they address the concern that comes up a lot when you're recommending it to the medical team. There are concerns that the use of nutrition support will stimulate tumor growth and metastasis, but studies in humans are limited and show mixed results. However, if nutrition support is clinically indicated, it should not be withheld because of concerns about tumor promotion. So from the National Cancer Institute, we have some data and they have their study cited there. So that's one of the things that will be brought up by some provider at some point when talking to them about can we initiate. Again, they use the 40 to 60 days as their cutoff as well. So cachexia, really the times that we have to help patients the most is the earlier we catch them, the better. So if we can get them in pre-cachexia, which this version is defined as weight loss less than 5%, or in cachexia, weight loss of greater than 5% with a BMI less than 20, or weight loss greater than 2%, or sarcopenia and weight loss. If we can catch them in pre-cachexia or cachexia, that's when we have the best chance to reverse that downfall, to get them really higher quality of life, all of those things. The refractory cachexia, as we said again, that's when you're in that last 3 months of life, you're not responding to treatment plans anymore, there is no more treatments to offer, and that's when we don't see any improvements in quality of life and length of life, any of those things. So again, the earlier we catch these people, the better. So nutrition support via enteral nutrition in refractory cancer cachexia has been shown to benefit quality of life of patients. True or false? False. Perfect. Timing is key, as we've said. I like this study that was done in 2019 showing the inadequacy of staffing as far as at least dietitians go. They showed an average of 1 dietitian to 2,308 cancer patients in staffing in the United States, with the average RD seeing 7.5. Everybody sees more than that I know, but they had a plus or minus there. But if you did that, I did the math on that. If they saw 7.5 patients a day, it would take 311 days to see each patient with 1. And so that's no follow-ups or anything else, which is part of the reason that I think that we catch people too late and then we're having trouble helping people at the right time. So along with that, ASPEN has a public policy advocacy where they're trying to get some legislation pushed through that would help to cover for other things other than what is currently covered by Medicare, including oncology education for nutrition. So not that that's the point of this talk, but I think that it's relevant that the more support we can get for payers and the more dietitians and nutrition support teams and pharmacists and everybody else that we can get behind us to start helping patients in the pre-cachexia or cachexia time before we're getting too late, and maybe help to prevent those 20% of cancer patients that die from the malnutrition, not from the cancer. So summary of those with curable disease: if a patient is planned for curative intent and not likely to be able to prevent malnutrition development with PO intake, then EN is advisable to support the patient. For those without curable disease, then you have to take into account how close do you think that they are to end of life, which is always hard because nobody has a crystal ball as well. So, but we do know if they don't have any more treatment plans or there is no more things that we can tolerate, then we know that we're getting close to that time. And then the paper that I was fortunate enough to be a part of, Dr. B led this. Ansley Malone did a great job of leading it as well. My partner on the oncology piece, Christina Swartz, did a good job. These are consensus statements as far as enteral nutrition goes from the Enteral committee from ASPEN. So these were what we found. It's not graded evidence, so it's not guidelines, because they were hard clinical questions about, you know, random controlled trials and all those things. It's just, what do we know from the literature that we do have, and then consensus statements from people that are working in the field. So not big changes from what we saw there, but these are what we had just published last month. As soon as feasible, use EN in adult oncology patients who have solid tumors and are unable to receive oral intake of greater than 60 to 75%, and present with moderate to severe malnutrition. So trying to get people earlier. Don't, you know, we want to do oral nutrition supplements. We want to do the pharmacologic medications if we can. Control nutrition impact symptoms, all of those things, but if we can't let them get too far to where we're trying to pull out the stops too late. So if they have moderate to severe malnutrition and we can't get those things done, then we should initiate as soon as we can. Using EN, if a patient is unable to get greater than 60% of their energy and protein needs by mouth, despite education and pharmacologic and oral supplementation, greater than 7 to 14 days. Consider post-pyloric short-term access or jejunal tube in those with refractory nausea and vomiting or intolerance of adequate gastric intake. One of the things that we saw both in the literature and that I see in clinical practice a lot is the nausea being like an actual gastroparesis from a lot of different reasons. You know, the pain medication, the lack of activity, all the anti-nausea medicines can sometimes, you know, lead into these things. When Medicare had their different guidelines and we were doing gastric emptying studies a lot, we were finding a lot of people that were having this bad nausea was actually gastroparesis to a moderate to severe extent. And then a lot of those people putting in a GJ tube, where it's one tube that's in both, with two arms on one tube, it tends to retract back up into the stomach because of that gastroparesis. So doing two separate tubes has been talked about in the literature, and I've seen been more beneficial for getting people to tolerate quicker and to treat the nausea so they have a way to vent these things. Consider symptom management and maximum oral intake for patients with refractory cachexia, life expectancy less than 3 months, Karnofsky performance status of less than 50, or those who do wish to continue anti-cancer treatment. So similar to what we've already talked about as far as reasons that we're not offering EN in these patients. So this is the Karnofsky performance status, that less than 50 is our cutoff. So it requires considerable assistance and frequent medical care. From there up, we can still offer, or we should still offer EN. If they're below that, then we're talking about getting closer to the end of life, and are they able to participate in their care? Is it going to be more of a burden? All those things. Don't forget about exercise. So I won't touch base too much on this, but once you establish a nutritional basis, don't forget to remind the care team that now we should get them moving and active to help with all of these nutrition impact symptoms that are there on the left. Head and neck cancer, NCCN has head and neck cancer specific guidelines. They have recommendations for, and I won't pull it up because I'm afraid I'll break it as I click the link, but they have recommendations for who should get a prophylactic feeding tube prior to concurrent chemo and radiation, who should get a reactive one, what qualifications do they need to hit? Is it that they're greater than 60 and they've lost 5% of their weight in the last month? Do they have a comorbidity that's getting worse because they are unable to have intake? They have all of that written down as a flow sheet so that it's not, you know, do I feel like they need it or any of those things. We actually have literature and guidelines that the doctors are also looking at. And so they're on those pages that I listed there. Head and neck cancer patients should routinely, prophylactically get a feeding tube prior to head and neck curative radiation. What do you guys think? True or false? False. Yeah. Again, we shouldn't routinely put them in you know, any populations. We should be stratifying and seeing who can we help. ASPEN is developing some head and neck resources, so a lot of this can just be a resource for you. There is, to Ashley's point, a revisiting of blenderized tube feeding, and they just published this handout for patients that had a large emphasis on considering blenderized tube feeding to help head and neck cancer patients gain weight, treat nausea and vomiting, help with bowel irregularity, improve oral intake, and prevent reflux. And then surgery, Ashley kind of touched base on as well, so I will skip over a little bit. Contraindications for feeding tubes in cancer. Prohibit peritoneal carcinomatosis, so if the cancer has gotten into the omentum and in that lining, we shouldn't be putting feeding tubes through there if we can avoid it. Chemotherapy, radiation-induced enteritis, malignant ascites, or chylosociety, because the cancer is eating through some of the lymph nodes and things that you'll see that we would prevent us from placing it. If they're on certain medications like bevacizumab as part of their treatment, then they can't have surgical procedures in 4 weeks, so they have to hold some of those medications. And that takes some planning, and are you going to have to get a bridge to get there? Are you going to have to place a short-term Dolpoff or NJ or something? Platelets have to be greater than 50 for long-term placement of feeding tubes typically. Many patients will have to be able to hold their anticoagulation or at least have a bridge, and they have to be able to get a window to the anatomy, however you're placing it. Types of tubes, head and neck cancer, I like to mention in the ASPEN Enteral handbook, the 2nd edition, they talk about how endoscopic tubes, where it's pulled past the site of disease and then into the stomach to pull it out, has a potential chance of feeding the tumor from where it is into lower anatomy. So then doing either a surgical tube or an IR place tube where it's coming from the outside, where we're not dragging it past disease, potentially has some benefits. And troubleshooting, many patients that are getting cancer treatments are getting antibiotics frequently, and they tend to knee-jerk add antibiotics for any irritation around the feeding tubes and whatnot. Most of what we're seeing in clinical practice is that it's usually a yeast because they've gotten antibiotics too many times. So using like a nystatin powder seems to dry whatever is there and treat the infection better than necessarily if you don't have cultures or something that you know is there. That's where we typically would start. Patients putting the gauze in between the outer flange and the skin instead of on the outside of that flange, so that it's making a moist environment that's rubbing all the time. We see that that leads to increased leakage and it becomes a vicious cycle. Treating hypergranulation tissue with silver nitrate before pulling the feeding tubes and as it's developing, so that you're not getting the leakage and the over responsive healing. And then there's our summary. And Ashley, you want to join us for questions? Thank you. Yes.
What are your thoughts on using pharmacotherapy for appetite stimulation in this patient?
Yeah, most of the data says megestrol. Oh, I'm sorry. What are my thoughts as far as using pharmacotherapy for appetite stimulant in this population? So most of the literature would support Megace for increasing the appetite and maintaining the weight, but it doesn't increase muscle mass and those kind of things. But that has the most literature behind it. It is a progesterone analog, so avoiding it in like PR, breast cancers and ovarian cancers and those things. We use dronabinol a lot off-label. or we're using it for nausea when the hopes that it will also stimulate their appetite. We have the most luck with olanzapine because it treats the nausea. Most of the time there's some stress component that's there. And it has help with sleeping and appetite and all those things. So we try and use a combination of or whatever we think is best for that population. Yes. Yes, I do have, it's on my work computer, so I can touch base with you and get it there. Yep.
Go to, and put you on the spot, that we get a lot of referrals from our outpatient oncologists, where they have the prophylactic thing to, high-fat formulas, like Ashley said, there's a lot of issues with the high-fat formulas, so not for you to be exactly brand specific if you don't need to be, but if you're in the field, what do you think would be the best tolerated, or when you say blenderized, are you referring to like a farms or a real food blend, or?
ASPEN was referring to like making your own blenderized formulas at home, or one of the commercial products that is already like a true blenderized one. So I don't think K Farms would fall into the category that they're looking for because it's just the phytonutrient blend that's in there. It would be like a true, it was food and we blenderized it and now it can go through a feeding tube.
I think my answer to that question would be kind of where the patient is in their course of care. So if they are planning for surgery, and if we're assuming these cancer patients are probably malnourished in some form, you may want to consider an immune modulating formula to get them ready for surgery. I think especially head and neck cancer patients, kind of like a ERAF type thing. But if it's, just there to help feed them through something else, they're not necessarily having surgery, just through chemo radiation, I would say standard. And I mean, the blenderized formulas patients tend to do really well with them. They really do. I mean, I know they're kind of old-ish, and there's not a whole lot of newer data with them, so that's why I didn't include a slide on them. But anecdotally, I feel like patients really tolerate them well in the long term.
Going back to the appetite stimulus, so at what point would you consider like inflation? I have an idea when you're providing for
The question was, when will we consider dose escalation for appetite stimulants, and when do we see if it's futile or if we're need to change our approach and all those things. So not a doctor, I'll start off by saying that, or a pharmacist. I just work with a nutrition support team with my attending. So a lot of times we'll start off with one of the agents, and then we'll do a 7 to 14 day follow-up with the nutrition education and those things. If it hasn't worked and we didn't start off at full dose, then we'll go to full dose. So if it was Megace, maybe we go from 400 to 800. And then if we're adding a second agent on, like dronabinol or olanzapine or Remeron or mirtazapine, those we would take a little bit longer to follow up on since they have to get into the system a little bit longer. So maybe a 3-week follow-up, but dietitian touching base in between as far as weight checks and can we optimize the diet and those things in between. I don't know if I answered your question.
Yeah, just based on your experience that you see with oncology patients, I'm just starting at a higher dose, starting at a higher dose.
If I have my say, yes, I would start at a higher dose, but not prescribing it, just only recommending. But yes, I would say just starting at the higher dose so you're not bringing them back in a couple weeks it's easier to go down unless you're worried about side effects. If you're worried that they're going to get a blood clot or what have you, then maybe starting slower or.
Not normally seen with the starting dose of maybe a 3 generally not.
Yeah, I don't have all the literature, because I was focusing more on the EN here, but I agree with the things that you're saying. I think we could do a whole nother talk as far as those things too. Thank you.
Question for you, but, are there any patient populations or specific cancer types where you wouldn't recommend MEGAs or other, appetite stimulants, as you kind of alluded to that clotting concern?
Yeah, so if they're immobile, a lot of times we won't choose, Megas, or Megastrol. I'm trying, y'all. And then if they're PR positive breast cancers or cervical cancers or any of those things where, you know, we might be feeding into that cancer process, we would avoid it there too. It can raise their blood sugars, so we would avoid it there too. If they're prone to being a little bit off as far as CNS wise, we might avoid dronabinol and some of those things. I believe olanzapine and metoclopramide are contraindicated together, so then sometimes we'll avoid those things. So yeah, it's a little bit individualized.
You made mention that there were some better outcomes with placing 2 tubes for a GJ feeding plan instead of just a normal singular tube we see.
Potentially.
Forgive my ignorance. Can you speak to that a little bit more? Is that just like one gastrostomy and one jejunostomy tube, or what does that look like?
So the question was about the GJ or a G and a J in patients that are having refractory nausea. So a lot of times we'll start off with a GJ, but if we find that it is truly gastroparesis that's causing it, or if we know that going into it, then we will place a G and a separate J tube, because the 2 arms on one tube, it has a tendency to retract back into the stomach because it's not having correct peristalsis. And so we can get quicker tolerance and less tube replacement if we do 2 separate tubes. So it would be a straight G tube and a straight J tube, as opposed to a GJ tube, which would be nice because you're only putting one hole in somebody, but not always. Sometimes it takes longer to get them up to goal, and then you have all these complications along the way.
I really loved your part too about considering where the cancer is, and there might be actually some contraindications of specific tube types based on where the tube is passing through. I thought that was just a really interesting point. I really thought about that.
All right, thank you guys.